Hi, this is Mayor Dwayne Warren with another coronavirus update. I am now with a medical doctor in the city of Orange Township, right here at 523 Park Avenue, and he has practiced medicine for some period of time. Actually, is a second generation doctor and second generation with his practice here in the city of Orange Township. Dr. Salerno, welcome and thank you for being with us.
Thank you, Mayor.
My office happens to be up on the third floor, and this used to be a dry, sterile place, but you've come in and given some pizzazz and some personality. Tell us about your taste in art.
So our thing is we like to take older buildings and kind of repurpose them, so that's what we've done throughout the cities of Newark, East Orange, and Orange. So this was originally a funeral home way back in the day. Then it became a not-for-profit and a law office, and so we took it over in January of last year. Our office is getting bigger and bigger. Our practice is up to about 110 employees. So we needed to make a centralized location. So we like to get creative. We like to kind of combine different types of, different types of textures, so it's hardwood, or it's stone, or it's glass, or it's acrylic. And the idea is we want to enjoy where we work because we spend so much time here.
That's right.
And so we want to make a comfortable, clean, inviting, and creative place, because I think medicine is as much an art as it is a science. So we want to be creative about it. So we try to be expressive as much as we can.
Thank you for what you've done. It's going to add some nice visuals as we talk here today. As extensive as your taste in art is, you have extensive experience in medicine, and you've been creative on the front lines of this coronavirus fight. Tell me some of the things that you've been doing so far.
So when we realized that it's here and it's not just another flu season, I gathered all together our staff. Again, it's like 106 of us, and I said, this is going to be a long haul. Our staff is young, it's a lot of single moms.
Right.
Most of the folks are under the age of 40. This is a challenge, for any generation.
Right.
And so I wanted them to first understand that my goal is to make them safe, because if we aren't protected, how can we serve the community? So we gathered everyone together. We said it's going to be a marathon. We're going to have to learn along the way. We have to put our tempers on the shelf and be able to adapt and evolve. And every day is a different day in the COVID, chapters.
Right.
So we got, as best we can, through all creative ways, the PPEs, which is hard to come by.
Right.
Especially, I didn't realize, but North America, we were the last continent to get hit with this, right? Asia got it first.
Right.
They depleted a lot of the global stores.
Right.
Then Europe and Middle East. And then it came to North America.
Supply chain was just depleted.
So it was gone, So we had to get creative. We went to auto body shops and got paint uniforms, that they use in the paint booths.
Oh, smart.
And that became our hazmat suits, and we disposed of them each day, And we got the necessary PPE, and then by good fortune, we were able to connect with Rutgers laboratory through Accurate Labs.
Okay.
And that's what got us on the radar for getting these test kits. And we were one of the practices to help with the FDA clearance on saliva testing, which is now FDA cleared,
yes.
A very safe and alternative means of screening. We, of course, were able to go from the painful nasal swabs to oral swabs, which is what we're doing now, and it's quick and easy and painless.
The big issue for us really is the mobile testing unit that's going to be in Orange on May 4th from 9 to 6 at the police station, and then the next day it'll be at the fire department, and the next day it'll be at City Hall, or some combination of that.
Whatever you guys want. Yep.
So I want to get to that because you're instrumental. I mean, you're the guy who helped us put that together as a great community partner. We thank you. But before I get to the mobile testing unit, just walk me through, we've heard a lot about testing and the reliability of certain tests. I understand there are 3 tests. Just walk me through the reliability, which one you prefer, and which one is most available out on the market.
So there are technically 4 tests. There's the nasal swab, gold standard, very painful. It's a different type of swab. It's like a bristle. It's not like a Q-tip swab, so you're really going up and you're scraping, and that hurts and that exposes.
And it's going into the nasal cavity.
Way up, yeah, and it's uncomfortable to the patient and it's also putting the tester at risk because you're exposed to coughing, gagging, sneezing, because you're stimulating a lot. Now we have the oral swab, which is like a Q-tip, just back of the throat, like you would do a strep test. 1, 2, 3, quick and easy. That's what we're doing. As accurate and as sensitive and specific, which are terms we like to use in science for accuracy. And then there's the saliva test, which we mentioned, which is just really just saliva into a cup. All of these are equally as accurate, as sensitive, and are FDA cleared. The last one, which is kind of like the snake oil, like in the old days.
Right.
That's that finger stick point of care test that you see a lot of people trying to push out.
Now, how does that work?
It's basically a finger stick, like if you were diabetic.
Right.
You get a little, like a little pulpit, and you pull out the blood, you drop it onto a card, and then if you get 2 lines, you're positive. If you only get 1 line, you're negative. So when we were doing this with Rutgers back in February and trying to see...
Which is a long time ago, given the development of this disease.
This test was completely inaccurate. We would get false positives, we would get false negatives. It was all over the charts. And so we really, and under the guidance of laboratories, kind of moved away from that.
So the prick test where you stick your little needle in the finger and you get blood, that you're not recommending because you don't find it to be accurate.
No, not especially when you're dealing with one of the most contagious, virulent viruses with silent spreaders that are the real challenge. And that's why everyone should really be tested, not just those with symptoms, because we need to find the silent spreaders. And so right now, the finger stick, there are a lot of, as you've heard, coming from China and coming from Europe, bogus tests, fake tests, fraudulent tests. It's kind of like a fake Gucci bag, right? But even the accurate ones are not that accurate as what I would say the gold standard. Because in medicine, we want to talk about gold standards. And the gold standard still is the swab or the saliva.
So there you have it. When you are getting tested, or if someone is trying to sell you a test, be sure that you first ask for the nasal swab, which has some pain, and then the oral swab in the mouth, and then a saliva test where you put your saliva in a cup and it's tested. The finger stick blood test is not that accurate, and the doctor's recommending that you not use that one, given that it gives false positives or false negatives. Thank you, doctor, on that. The next thing everyone wants to know about, the president's talking about this all the time, but we're not getting anything that's clear from any medical voice. Medication. Is there anything that you're recommending or that you're using that can either stop the spread, alleviate the symptoms, or outright kill off COVID-19?
So that's, again, an algorithm that changes literally day by day. So in my experience, and again, we're talking 8 weeks, right? I mean, clinical studies we like to measure in calendar months, if not years.
Right.
But we don't have that because lives are being lost or jeopardized. So and then you hear, Dr. Oz and you hear Dr. Fauci, they're all talking about antidotal, but that's all we have right now, because we're talking about what we're learning on the go, in the hospitals, in the nursing homes, and in the community clinics. So I've had, and have been going to the Plaquenil drug, the anti-malaria drug.
It is the name for another drug that we're familiar with. Those are up on the screen. And I'm just going to have the doctor walk through what he's found in the using of that particular drug.
So the Plaquenil, otherwise known as hydrochloroquine, we've been using this and to treat patients, and we find that early intervention is the best, because what we know so far is we want to try to identify positive patients.
Now, what is early? Once I know I've been tested and I'm tested positive?
Correct.
Or if I've been exposed?
Well, we'd like to say, right now the guidelines are, and the pharmacies are asking for a known positive test before you can prescribe and disperse the medication.
Okay. So known positive
so
test is the key.
You need that positive report in order to get a prescription filled and a prescription called in. Okay? So ideally, you come in, you get swabbed 48 hours or less you get your results, and that is true. It's not 5 to 7 to 14 days, which was the case at the beginning of this, situation. And you get the result, and then a prescription of Plaquenil, and there are a couple of different doses, but it's typically a 5-day course of treatment. There's a loading dose on day 1, which means more milligrams you're getting on day 1.
And this is by pill,
These
by
are
tablet?
pills, yes, by tablets. Easy to swallow, small tablets. They're about the size of a Tylenol caplet, you know. And then days 2 through 5, it's twice a day, 200 milligram dose that you're taking. The interesting thing about Plaquenil is one tablet lasts about 40 days. So in medicine, we talk about half-life. How long does a medicine stay in your system? These medicines stay a very long time in your system. That's why they were used for prophylaxis when you were traveling to malaria countries, because you would take it and it would stay with you during the course of 2-3 weeks while you were in a certain region of the world, you know? So, again, it's been around 70 years. I mean, this is a time-tested true. It was used not only for malaria, it's used for rheumatoid arthritis, it's used for systemic lupus to maintain these autoimmune conditions.
Have you prescribed it, and have you monitored patients that have taken it?
Yes. Not only patients, family members, you know, my own staff, because unfortunately we've had a lot of staff infected despite all the barriers, because we're exposed to 200, 300, 400 patients a day in all our different sites.
And what are you finding as to those? Have you had instances where you prescribed it and the person agreed to take it, and you prescribed it and the person agreed not to take it? Has there any?
Correct. So here's my own little tiny kind of studies that we did here. We had at least 2 instances, people within the same department, literally even before the 6 feet of social distancing were 2 feet apart, and not involved in direct patient care, but back office, so property management, IT, different areas like that, call bank, just answering phones and making phone calls. So in 2 instances, I had a staff member taking Plaquenil, and again, we're learning as we go along, so this isn't FDA approved, this is kind of off-label. So we were taking Plaquenil once a week for prophylaxis, prevention. So one member...
And when you say prophylaxis, you mean taking it so that they can prevent getting the infection at all?
With the intent that it would help prevent getting infection. So again, this is not FDA approved for this. A lot of times in medicine we get creative. We use medicines, as they say, off-label. This is an off-label situation.
And I'm going to ask you about compounding soon too.
Sure. So Plaquenil off-label, because we're not, I mean, technically Plaquenil doesn't even have FDA approval for the treatment. We don't have any FDA proven therapies, right, for the treatment of COVID.
At this point, nothing for COVID at all.
We are trying different combinations, different cocktails, if you would, of holistic things like vitamin C and zinc, prescription medications like the one you've seen from Gilead for Ebola virus, Ivectin, which is an anti-parasitic medication, Plaquenil, an anti-malaria medication, Z-Pak, doxycycline. We're trying a lot of different combinations.
All these things will appear on the screen so that you understand the spelling. If you have further questions, you can ask using this information. But he's basically pointing out the attempts that they're making to try to see what works. None of this has been tried and true. The FDA has not approved any of it. There's no particular cure at this point for COVID-19, but these are the kinds of drugs that have some effectiveness that's used as a starting point for seeking a cure.
And this is what we're hoping may lead to, as we get to the second, God forbid, phase, which we're predicting is going to happen in the fall and winter, that we're going to take lessons learned and quickly take this data, analyze this data, and hopefully come to some algorithms or standards that we can try next time around to not have to quarantine the entire country, you know? So in this case, we had 2 staff members. One chose not to take it. One chose to take it just once a week. And so 4 or 5 weeks into the COVID crisis, in the 2 respective departments, in one situation, the 2 guys working literally in the same office, 3 feet apart. The one who didn't want to take it, young, healthy guy, felt like, you know what, I have nothing to worry about if I do get it. He got it. He had very mild symptoms. We tested him. After 5-6 days, we tested him. So that was 5-6 days. He was in the same office with my other staffer,
Right.
who chose to take it.
Right.
And the gentleman that didn't take it was in fact positive for COVID, documented.
Wow.
We put him under plaquenil treatment, took him out of work for a week. The gentleman who chose to take the pill once a month, once a week, every week, we tested him, he was negative.
Wow.
So, I mean, you know, what...
That's one person, one test,
Yes.
but it worked in that instance.
It did, and we know this is a highly contagious disease.
Right.
That's what makes it so different than strep throat or a sinus infection or walking pneumonia. It's highly contagious. That's why we're wearing masks, doing
That's right.
social distancing, and being in isolation. So how would you explain that, you know? And then in another instance, same thing, 2 people working in the same department. One was on it, one was not on it, and the one that was not on it got COVID, documented, and the one that was on it didn't get COVID.
Wow.
So I have 2 separate instances of 2 people in close proximity working as, you know, a pod, we call them pods. One was on the prevention, one was not. Again, off-label, experimental, thinking outside the box.
But there is a starting point for the entire globe to look at when they start to study.
We're all going to be
vaccines.
studying this, because if we don't study and learn from this, then, you know, what makes us, you know,
Right.
who we are.
Now, we put these medications on the screen. What kind of intelligent questions should we be asking our doctors about these medications, about cures and things we should do for next steps?
Well, I think it's not a one-size-fits-all approach. I mean, these medicines have to be tailored also to you as a person and any existing medical conditions. Because what's the biggest concern you've heard right now, and the pushback with plaquenil, hydrochloroquine, and Z-Pak, azithromycin? It's been potential cardiac arrhythmias, irregular heartbeats, QT prolongation, okay? That's been the big reason why people aren't just rushing to market.
So your medical condition really matters when looking at drugs. So that's one of the questions they need to talk about.
You have to know
is
your
recognize your medical condition.
Correct. You have to know your past medical condition, okay? You have to know your what we call comorbidities, okay, to determine it. Again, we don't have a gold standard. Some people perform well with one experimental treatment. Some people perform well with a different experimental treatment. And that's why we're calling them just experimental right now.
And none of these are home remedies that you get your hands on some of the substances. Second, everything should be going through your medical doctor.
Everything, yeah. I mean, we're saying vitamin C, we're saying zinc, we're saying melatonin, we're saying vitamin D. And some of these, yes.
Well, that's my next question. Some things you can get over the counter. What are you recommending for the thing that I can do as a person who I recently tested negative for it? I went through the swab painful test. What can I do to keep myself healthy?
Well, again, every disease is about prevention, right? So we want to prevent heart disease. We want to prevent cancer. So we take what we know are preventative measures: eating clean, taking good sleep, taking care of your immune system. It's all about the immune system, right? So vitamin C, zinc, melatonin, vitamin D, we know that those have, you know, like immunomodulating qualities, and they can improve your immune system. So you are less susceptible to, you know, getting the virus attached within and replicating within.
So I can get vitamin C at my pharmacy?
If you can find it. Yeah, I mean, right now, I don't know how many people have gone. I tried to go in Walgreens, CVS, vitamin C's out, zinc is out, you know, so there's a shortage.
But no prescription for those, you can buy those.
And there's a shortage of those, you know, so I think, you know, I think also the other thing too, you know, so many people are quick to pop Tylenol, you know, fever sometimes is a good response. And we shouldn't be taking, you know, Tylenol or anti-fever medications for low-grade fevers of like 99 and 100, right? We want to, you know, we want some fever as part of the immune response to fight the virus, and you're blunting that response if you're so quick to run to Tylenol all the time. Okay. So we want to really save Tylenol for that 102 or higher fever.
So 101 and under, we don't necessarily need it because that means our body's fighting.
That means our body's fighting. That means that there's a, for lack of better words, a chemical reaction going on, and this is the effect of it, you know, that's being generated. What you want is when you have any type of fever, you want fluids, because fever will dehydrate you.
Right.
Fever will dehydrate you like a hot summer day. So you want the fluids, you know, you want the water, you want the low sodium fluids, you want the herbal decaffeinated teas and things like that, because you want to replenish what you're losing through the fever going through your, you know, skin surface. So, but again, let that body and let that immune system start an attack, and then take the Tylenol when you're 102, you know? And I think two important pieces of instruments everyone should have is a digital thermometer during this time, and a pulse ox, you know, where you can check your
I know
oxygen.
the thermometer is, you put it in your mouth, put it under your arm.
Yeah.
It gives you your temperature.
Exactly.
And the other device is?
It's a pulse ox where, if you've been to any hospital emergency room, they put it on your finger.
Right.
It gives you an oxygen and a pulse level. That's very important, because what we've learned and what we're learning with COVID is, you know, you see people walking around with very low oxygen levels, yet they're not huffing and puffing. They feel some shortness of breath, but when you correlate it with their pulse ox, there seems to be a big gap range between their, you know, ability to function and how low their oxygen levels are. So a pulse ox is important because we want to identify early on the subpopulation of positive COVID patients that are running low oxygen levels.
And pulse ox can be found in the pharmacy?
Pharmacies are Amazon.com. I mean, I've been
so
telling
they're
patients
popular.
just go Amazon, get digital thermometer, get a pulse ox. You could get it delivered to your door within, you know, a day. So
You'll see those things on the screen. Those are devices you can use. You can use those at home,
100%.
and they'll give you your readings so that you can monitor your health. Tell me now, my wife is a doctor in the emergency room, and many times they have to intubate people, but there's been a high instance of people not recovering after intubation. What is that about?
So initially, you know, we thought, and again, we're looking at historical perspectives of previous pneumonias, previous viral pneumonias, the SARS infection and the H1N1 and the swine
Yes.
infection. And so we thought, okay, this pneumonia is going to behave the same way, and it may cause this ARDS syndrome, ARDS, acute respiratory distress syndrome. And we know historically, when a patient enters this critical area of lung damage, mechanical ventilation helps, early and quick.
And that's what intubation is, mechanical, helping you to breathe.
Yes, a tube down your windpipe hooked up to a machine with the proper, you know, adjustments, and to help you breathe, to help you ventilate, to help you oxygenate so your organs don't start, you know, not getting oxygen. But what we noticed is 5 days, 7 days, 12 days, 18 days, and these patients aren't coming off the vent.
And vent is another word for intubate, to help you breathe.
Exactly. And so we were seeing a very high mortality death rate associated with ventilation. And this was really demoralizing, humbling, and you know, to us to see this. And so, again, we're learning about this virus. We're learning the patterns and the behavior of this virus. And there's some, you know, now schools of thought and that we're seeing that this virus is kind of behaving almost like high altitude sickness. And in that case, you don't want to be quick to intubate, but you want to just give free-flowing oxygen.
Right.
And you want to, you know, move the patient, and you want to, you know, not lie down on your back and have the whole weight of your body on you. You want to sit up, you want to be on your side, you want to lie on your stomach, you want to move around, you know, but you want to have high free-flow oxygen. And so what we're seeing now at, you know, at some of the, you know, hospitals that are now moving towards this school of thought, and many of them, that this is potentially, you know, reducing ventilator use and ventilator associated, unfortunately, death due to COVID. So, because that's the weird thing, like I see in our tents at our offices, patients come in and we do the blood pressure and we do the temperature and we do the pulse ox.
Right.
And we're seeing pulse ox is 86%. Yet they're not gasping.
That's your breathing rate, that's your oxygen rate.
That's your oxygen rate.
What is a normal oxygen rate?
97, 98, you know, if you're not a smoker.
And what is low and dangerous?
Well, 86, and like if you, God forbid, walk, you know, never a smoker, never exposed to that, I would expect you to be talking in 1 or 2 word sentences, because you're gasping for air.
Right.
You're hungry for air. You're using your accessory muscles in your neck and your chest to move air. Yet these patients don't look that way. They're not behaving that way. Yet their pulse ox is 86%, 82%. Sometimes when they're in the emergency room, you know, they might be in the high 70 percentile.
That's very low.
That's extremely low. I mean, but they're functioning. You know, they're not crashing at that level, you know? And so that's why, you know, we're looking now at the concept of free flow oxygen, pulmonary therapy, okay? You know, there's things called pulmonary therapy, like there is physical therapy, you know? There are certain medications that we use in high altitude sickness, you know, like Diamox and steroid and things like that. So again,
Any other machines that are able to work aside from the vent?
the BiPAP, you know, so for those who have sleep apnea disorder, they're used to CPAP machines.
Right.
Well, there's something called a BiPAP machine, very similar. It's not a tube that goes in, it's just a high pressurized, tight fitting mask that really truly blows the air all the way down into your lung trees. You know, you're not, you know, you're not sedated, and you're not on a ventilator, and you're not having, you know, a machine literally breathe for you. This is just a machine assisting you by blowing air into you.
And it's called a BiPAP machine.
BiPAP machine, yes.
Another question for your doctor to determine whether or not that kind of therapy is good for you. We spoke earlier, and you told me that there are some ways that really someone can convert their house through telemedicine into a mini clinic where they could receive help,
Yeah, I mean,
in conjunction with their doctor, in conjunction with their pharmacist.
and in conjunction with the visiting nurse agency, and in conjunction with the home respiratory agency, which we have all of, right? So our goal is early intervention and really allowing people to be home, less exposed to other viruses and other illnesses and overburdened healthcare system, which we're still kind of overburdened, very
Sure,
much so.
sure.
So if you could get the early intervention by early detection, which is testing,
Right.
and then we look at that person, look at their, you know, comorbidities. Are they diabetic? Did they smoke? Are they over the age of 50? Are they morbidly obese? You know, then we are able to say, okay, now we need to, through remote patient monitoring, which is modern technology,
Right.
in your own house, you could get set up where your temperature, your pulse, your blood pressure, your weight, your sugar, and your pulse ox, 6 key vital indexes, could be measured and monitored remotely. So the patient is doing this at their own home, Bluetooth technology, and it's going back to their doctor, to their clinic, who could be monitoring it just like a nurse would be monitoring it every hour, every 3 hours, every 6 hours. And, you know, and then depending on what your oxygen needs are, you can get free flow oxygen. You've heard of people with home oxygen,
Sure.
or COPDers,
Sure.
or emphysema patients. Well, now if we're thinking free flow oxygen is the way to go, and home nebulizer treatments are the way to go, and you do the, you know, the holistic approach with the C and the zinc and the vitamin D, and then you look at the other, you know, experimental modalities like the Plaquenil, hydrochloroquine, doxycycline, you know, the Gilead medication that you're seeing for Ebola with pretty high success rates. You are seeing options that, you know, again, early on, can hopefully avert that crashing too little too late situation.
So you won't wind up in the hospital.
Exactly, because the problem with this COVID virus, you could go from good to bad in 24 hours.
Wow.
You know, it's not a time sensitive virus by any stretch of the imagination.
So monitoring is, wouldn't you agree that monitoring is a good method of trying to at least minimizing the effects of COVID? Because the last thing you want to do is have to go to the hospital.
If you can, yes, that's still, because right now, again, the hospitals are overburdened. Unfortunately, the hospitals are getting some of the patients that never got detected too late on, didn't get any type of intervention treatment whatsoever, and you know, they're the hotspots right now. Hospitals and nursing homes are the hotspots.
I got 2 more items. One is very important. I'll save, the last one's going to be your recommendation on how we stay healthy. The city of Orange Township has about 30,000 residents, a little bit over 30,000 residents. We have 4 wards in our city. We have a very diverse population, diverse in terms of culture, in terms of age, and in terms of socioeconomic background. And socioeconomic background, I mentioned that because some of the comorbidities tie into that.
Yeah.
So given our diversity, we put the call out, and you came with an initiative that says we can test everybody and we can have a mobile testing van to do it. You've spoken to our health department, we've teamed up. We want to thank you for the public service that it provides. But tell us, what are the procedures that are going to happen? I know there's going to be a testing van. We're going to make it accessible at the fire department, at the police department, and at City Hall. Those will be on separate days. But we're also going to be working with your office to go into senior buildings to test that population, because given the density of the residents and their age and other morbidities, that testing site should remain by itself where we test seniors alone. But let's first walk through the mobile testing unit and how it works.
So the mobile testing unit is basically taking what we're currently doing at brick and mortar locations and putting it into a Sprinter van that we retrofitted. So it's got Wi-Fi, and it's got a sink, and it's got refrigeration, and it's got a pop-out kind of tent awning kind of thing. And so what we want to do is kind of like, you know, what an ice cream truck was to ice cream, we want to do for COVID detection and treatment.
You come with trained staff?
We come with trained staff, so you're going to have staff that does the blood works, phlebotomists that are drawing the blood. Why are we drawing the blood? 2 reasons. 1, we want to see, have you had the infection?
Right.
So we're looking for immunity.
Now that's the antibody test?
That's the antibody testing that you've heard so much about. That finally, yes, it's available at all the commercial labs. So it's antibody testing for past infection and questionable immunity. So that's one characterization of patients we want to identify.
Right.
It's the swab, the throat swab, takes 3 seconds, painless. That's to tell us if you have an acute infection. Are you infectious to others? Are you a silent spreader? Because again, as you mentioned about, you know, neighborhoods and economies, why are we seeing cities like Newark and Orange and East Orange getting hit so much harder than cities like Livingston? Because you have multiple generations living under one roof.
Correct.
Just like in Italy. In Italy, it's very common. You're going to have 3 generations under one roof. And up until, you know, the U.S., Italy was the most hit with the mortalities. So we want to find out, you know, if the grandchild, you know, or the teenager is a silent spreader because he's living in the same house with his great aunt or his grandmother. Right. So the swab is testing for that. And then we're doing blood works because, again, looking at and what we're learning, we're looking for what we call acute phase reactants. Okay, so there are things in the blood that can tell us if you're simmering or if you're really boiling with potential COVID. So if you have a positive active test, meaning you have the infection, you're infectious, you're active, we do acute phase reactants to just kind of advise us or guide us or gear us, like, are you potentially at risk for complications of COVID? You know, and so these are, you know, what we call, again, acute phase reactants or inflammatory markers.
So you take those 3 tests, the 2 bloods, you take the swab, and then you seal it. You test it on site, and you send it to a testing site?
No, it all goes to a lab.
So it goes to a lab,
yeah,
to be tested. And how do I find out the results?
So within 48 hours, you will find out the swab to see if you're acutely infected and infectious. And then not too long, like a day or 2 after that, you'll have the antibody test.
And all this is completely confidential if you're tested negative?
If you're tested negative, if you're tested positive, it goes to the Board of Health because it's a reportable illness, no different than, you know, hepatitis C and
right,
HIV. But I think the importance is, and what everyone really needs to know, and again, we're not trying to scare people, but this is part 1. There is a part 2 coming.
Right.
It's going to come in the winter. So if we don't learn from this, and as a public-private sector join together, you know, each community together, because this is you know, a grassroots movement that we have to do ourselves. We have to be prepared for part 2. So I think the importance of the massive testing right now is identify 3 categories of patients: active infectious, past infected, and for lack of better words, the naive virgin patient that never got it.
Right.
Because that's the patient that we have to worry about comes phase 2, you know, and when we leave the warm days of summer and the long sunny days of summer.
And we have to deal with that. Doctor, you have to bring information with you. What do they have to bring?
So your office will be working on some available forms that we're giving you to
Yes.
download and print. So obviously, like any type of medical registration, it's a standard form. One is asking your basic information, name, address, date of birth, emergency contact, and different contacts, email, cell phone, you know. And then the other one is very important because, again, we want to identify, but we also want to, for lack of better words, risk stratify. And the other one is just a little bit of a patient history, again, private, confidential, HIPAA compliant, that just tells us, did you smoke? Did you drink? How old are you? What allergies do you have? What medications are you on? And what medical conditions? Because again, if you're 50 or older and you have diabetes or hypertension, you're a cancer survivor, you have chronic kidney disease, and again, you know, what do we know right now about African Americans and Hispanics? It's the comorbidities of diabetes and hypertension that's causing a great disparity in the infection and the mortality associated with COVID.
So you want to know that up front.
Yeah, because if you're 32 years old, you have no medical history, you never smoked, I'm not so worried about you, although I'm not, you know, completely ignoring you. As opposed to if you're 52, overweight, you have type 2 diabetes, maybe you're not the best controlled diabetic. You're in a different category right now. And so again, you know, we want to be able to identify who's positive, look at how much acute phase reactants they may have kind of circulating in their system in response to the COVID, and what are the other factors that might make this a bit of a challenge.
What does it cost, doctor? It's not totally free to anyone, but you do take insurance, correct?
Yes, so as you know, Medicare, our you know, federal healthcare system, has set COVID pricing at the laboratory pricing at $102.15, something like that. So that is the standard pricing as set forth that insurers have recognized, state, federal, and private, and that is what the cost is of the test. And then there's the medical component of the test. The medical component of the test for non-insured patients is $50, and then for the insured patients, it's what the insurance pays. So for those who are insured, you know, just bring your insurance card. If you have a primary care doctor on your insurance card, like a managed care type of thing, you just need to bring a referral from your primary care doctor.
There's a prescription that says you can go and get the COVID testing.
Yes.
So for those of us who are uninsured, the total price will be $152.15.
Correct.
Okay. And that's payable cash, check, money order?
Sure. Yes.
Whatever medium you want to pay, but it's payable on the spot. You don't pay, you can't get the test, because you can't send it to the lab because they want their fee.
Yeah, because I mean, these are commercial labs, and there's a cost to running it. There's reagents and chemicals and things like that. And, you know, you have to extract the potential virus from the specimen. You have to run it through reagents. It's a process.
It's a huge process. So for the overall price of the test is $152.15. If you have insurance, bring your insurance information, and then they'll determine what your eligibility is. If you have a doctor, you may have to get your doctor to give a prescription. But not in all cases do you need to have a doctor's prescription. That's only if you have the managed care type of insurance.
Correct. And on your insurance card is the name of your doctor, which kind of tells you you're in a closed network.
The doctor doesn't have this is not a charity care situation where you run into at the hospital. This is a hard cost that has to be absorbed. Either you pay it or the insurance. Doc, one last thing. Separate from the mobile unit, you'll have a team that can go into senior buildings that have at least 200 apartments full of seniors.
Yes.
How are we going to work that?
So we're actually very familiar with this because about 20 years ago we started a house call program called Senior Healthcare Outreach Program. So on Oakwood Avenue,
yes,
you have 400 Oakwood Avenue, 268 Oakwood Avenue, 300 Oakwood Avenue. So these were buildings we do house calls in.
Right.
So just like in the old days. So basically, I think it's very important that all the senior buildings truly identify which category are their tenants in, because those are gonna continue to be hotspots as we move through into phase 2. So what we're suggesting and what we'd like to do in conjunction with building managers and social workers of the buildings is just set up, a testing day or two. So we're either downstairs in the common room, and social isolation, people come down the elevator, go out, get tested, back in the elevator, back into their room.
They can be out of their house and back into their house and have been tested
In
all
10
within
minutes.
30 minutes.
Not even 10. If the paperwork is filled out, it's 10 minutes. The swab is 30 seconds.
Right.
The blood test is maybe 2 minutes.
There you have it. Within minutes, we're going to set up this senior housing program where you come in, you come out of your apartment, you'll be back in your apartment within 15 minutes of being tested. Please stay tuned for that, as my office will be reaching out to all of the management, all the social workers, and Dr. Salerno to put together a schedule when we can start that program in the senior houses. But the mobile testing van will take place on May 4th. We'll have it at the police station, which is at 29 Park Street in Orange. The next day, between 9 a.m. and 6 p.m., which is Tuesday, May 5th, City Hall. And then a third day, we'll have it at the fire station on the corner of Lincoln and Central Avenues in Orange. Bring your insurance information, or bring $152.15. Bring the form that you're going to need. It's important that if you could pre-fill the form, it would be more expeditious for the treatment option and for everyone to get treated on a more timely basis. My office and the city website will have a copy of the form that you can download. We're also going to try to make hard copies available. If you go to the lobby of the police department at 29 Park Street, the forms will be available there. Remember, Monday, May 4th, between 9 a.m. and 6 p.m., the mobile testing unit for COVID-19 will be available. And that comes through a partnership with the offices of Dr. Salerno and the City of Orange Township. Doctor, thank you for being a key community partner. It's at these times when real leaders and real partners rise up, and certainly you've done that with this great service. We want to thank you.
It's an honor to work together with the public office. Thank you.
If there are any questions or concerns about the mobile testing unit, you may call the mayor's hotline at 973-280-1621. That number's on your screen. And of course, you can always call me, Mayor Warren, at 862-373-0025. Remember, us in the community with our private partners, if we work together, we can beat the coronavirus.